So welcome everyone on behalf of Hope and Cope. Again, my name is Carly Berlin. I'm the Wellness Center Program Manager at Hope and Cope. We are joined today by Dr. Joe Schwarcz, who is a professor in the Department of Chemistry at McGill University and the Director of the Office for Science and Society. And he helps demystify science and separate sense from nonsense, fact from fiction through newspaper columns, radio shows, blogs, books, and we're very, very grateful for him to share his insight today from a scientific perspective about the COVID-19 vaccine. Just a reminder that this is a scientific perspective and should not be taken as medical advice necessarily. It may help you understand what the vaccine is all about. But the recommendation that we've gotten from our colleagues at the Jewish General Hospital in oncology is really to get the vaccine as soon as you can. And if there are any nuances for your particular situation in treatment, that's something to direct to your healthcare team. So thank you so much, Dr. Joe. We're so happy to welcome you, and I'll let you take it away.
Well, thanks very much for the invitation. And let me just give you a touch of background on what it is that we do here at the office. And it's very simple. We try to separate sense from nonsense. Simple to say, but pretty complicated to do, because there is a lot of nonsense out there that needs to be demystified. You can go to our website, get a lot of information. You see the address at the top. We produce a bi-weekly online show visually called The Dose of Science, and you can get all the info there on our website, or you can see it all on our YouTube channel. There is, unfortunately, a lot of nonsense out there. And our task is to take that proverbial snake oil and replace it with science. It is a challenging thing to do, for sure. And we are constantly dealing with quackery. What is that? Simple definition is just people pretending to have knowledge that they do not actually have. Very often represented by a duck, and that explains why I collect ducks. And if you are ever around the chemistry building at McGill, I'd be happy to give you a duck tour because I have several hundred of these. The reason for this is to emphasize that we are constantly surrounded by nonsense and by quackery, and that we have to be on our toes to try to combat it. Well, of course, today the topic of discussion is the virus. And we've seen these frightening pictures now for a year. And our world basically has suffered. It is indeed temporarily closed. We have our ups and our downs, but it is indeed a pretty disturbing situation. And of course, whenever you have a situation like this, the quacks enter the picture. When science doesn't have all of the answers, they will go into the vacuum and fill it with their nonsense. We have people like Alex Jones on TV recommending colloidal silver as a cure in India. And here as well, some people are recommending homeopathic remedies. This is total nonsense. Homeopathy is the most absurd of all the alternative practices. Homeopathic medications contain absolutely nothing. They are diluted to the extent that there's not a single molecule of the original in there, not that the original would have had any effect anyway. And then, of course, we have the nonsense of the anti-maskers. This lady here at a hearing in Florida gave a rather interesting reason for why she doesn't wear a mask, because she likes every part of her body to be able to breathe. So she's not going to get any underwear commercials. Then we even have, believe it or not, physicians who recommend medications that have been shown not to work. For example, hydroxychloroquine, which of course was championed by Trump, and America's frontline doctors, who really are not specialists in this at all, but some of them are ophthalmologists, still believe that this is the way to go, hydroxychloroquine. And unfortunately, these people do have a following, people like Madonna. And of course, when you have someone like that, who has hundreds of thousands, if not millions of followers, people will abide by what celebrities recommend. You have people like Woody Harrelson, who claims that COVID is caused by 5G networks. I mean, this is just totally nonsensical. But these people are put on a pedestal because they're celebrities and they have a voice. Then, of course, there are the immunity boosters. Well, this is interesting business because you do not necessarily want your immune system boosted. If you have some autoimmune disease, you don't want a boost in your immunity. But for COVID, I mean, there are all kinds of claims about dietary supplements, such as elderberry having benefit for COVID. There's zero evidence for that. The immune system is very, very complicated. And this idea of, quote, boosting the immune system really doesn't make scientific sense. You can have an effect on certain parts of the immune system, but boosting the immune system as a general term just doesn't make any sense at all. There are no specific foods that you can eat to boost your immune system. The only recommendation that we can give is that if you have a healthy diet, and we know what that means, eating mostly foods that are unprocessed. You want your fruits and your vegetables, that should be the main part of your diet. And if you have a healthy diet, everything else works well in the body. But there are no specific foods to boost the immune system. That's just a lot of nonsense. However, there are a couple of supplements that are worth looking into. Vitamin D. Vitamin D, especially here in our climate in Canada, during the summer, we don't have enough sunshine to trigger formation of vitamin D in our system. So I think it's a pretty good idea to supplement with this because there is actually evidence that people who are very low in vitamin D in their blood levels are at increased risk for contracting all kinds of infections, including COVID-19. So 1,000 to 2,000 international units a day is certainly not a problem. There's no toxicity there at all. We're not sure that it is beneficial, but I think it's a reasonable bet that it may do some good. The other one that you probably have heard a great deal about is zinc. And this is a little bit of a different story. Again, we know that people who have low levels of zinc are more prone to infections, but here you do have to be careful about overdosing. You do not want to go above 50 milligrams for sure, because when you do that, excessive amounts of zinc actually can suppress some parts of the immune system. So as with so many things in life, it is the dose that matters. And you certainly can take a small zinc supplement to make sure that you don't have low blood levels, but this is one thing that you do not want to overdo. Although I can also tell you that with the North American diet, it is very unlikely that people have a zinc deficiency because zinc is plentiful in many foods. You find it in meat extensively, for example. Now, just before we get on to the meat of the matter, I just want to tell you to be very vigilant about scams. And Interpol has been very active in this because any time when there's a situation like we have now with COVID-19, you can rest assured that the scammers will get into the game. And they have gotten into it in many different ways. There are all kinds of supposed vaccines being sold on the internet. These are websites that tell you that you can kind of skip to the head of the line. You can buy the vaccine from them. No, you cannot. There is no legitimate vaccine that is being sold on the internet. Whatever they are selling is not a COVID vaccine. It is just absolute bunk. Do not fall for this. Do not get into any kind of surveys where they ask you about your opinions on vaccines, where you have to put in any kind of personal information. Do not ever put any personal information on the internet except to known sources. So there's nothing that you can buy on the internet which is in the vaccine category or which treats COVID-19. Social distancing is what we know works. It's not particularly appealing, of course, and really we should be using the term physical distancing because you still want to keep in contact with people. You don't want to be social distancing, but we need to do physical distancing. And people are being very inventive about how to protect themselves from each other. Sometimes I think going a little bit overboard, but this is what desperation makes people do. And there are all kinds of approaches that are being taken to ensure that we are not exposed to this virus. We can go back to 1918, which is always interesting because we can learn from history. Obviously, we had a pandemic very similar to the one we have now, actually worse back in 1918. So how did we deal with it? Well, very much like today, churches were closed, schools were closed, shows were closed, sporting events were canceled, quackery appeared then as well, all kinds of supposed miracle medicines. And again, people were inventive. They would wear masks. They didn't know as much as we know today about transmission, but they knew enough that masks were beneficial. If you didn't have a mask, you would make use of various kinds of cellophane wrappings. And if you didn't don a mask, well, there were consequences. Today, we don't tend to shoot people because they don't wear a mask. That's a little bit excessive. Dr. Thomas Tuttle was a public health official in those days, very much like Dr. Fauci today. And what is fascinating is to look at the recommendations in those days. Avoid crowds, walk to work, do not spit on floor, sidewalk, don't use common drinking cups. Exactly the kind of recommendations that we are doing today. And interestingly enough, back then, over 100 years ago, there were people who defied those recommendations, and we see the same thing today. Dr. Fauci is sort of the parallel of Dr. Tuttle, and as you know, there are people today who insist that Fauci is wrong. They think that the mask that he's recommending is useless, and that we should be hugging each other instead of wearing masks. Well, you couldn't be more wrong than that, because one thing we know for sure is that the closer you are to someone, the more they are in your breath atmosphere, the greater the chance of transmission. But unfortunately, these anti-maskers are out there and in full force about my body, my choice, no masks. Well, it isn't exactly their choice, because their choice affects us as well. If they become infected, they will spread that virus. So when they are out there burning their masks in these ridiculous demonstrations, what they are really doing is setting up a situation whereby they are going to be transmitting that virus. All right, now let's get down to the science of this virus. And I'll try to make this as simple as possible. You've been inundated with pictures like this if you've been cruising the internet. That's the virus, and it's a pretty complex entity. We do not talk about it, or should not talk about it, as living or dead, because viruses are not alive. A virus can only replicate inside of a cell. So there's no such thing as a live virus. The terms that we're using is why a virus can be active or inactive, viable or not viable. Those are the proper terms. Let's take a look inside of this virus. In a simplified way, what we have in there is this long coiled molecule, which is its genetic code. This is its ribonucleic acid, or RNA. And this tells that virus which proteins to produce, because proteins are the essence of the virus. And this is what enables it to enter into cells and to inflict its genetic machinery into a cell so that the virus can replicate. Well, part of this genetic code is the code for the so-called spike protein. And in this picture, that's the yellow stuff that you see on the surface. That looks kind of like a crown. That's why these viruses are called coronaviruses, because they are encircled by a crown. Well, in order for this virus to produce that spike protein, it makes use of a gene. And that gene is just part of this long chain of RNA. And this spike protein is what it needs to infect a human cell. And this happens by what we refer to as a lock and key mechanism. So you can kind of think of a human cell as having certain proteins on its surface which behave like a lock. And for the SARS-CoV-2 virus to infect the cell, it first has to latch on to that lock, very much like a key would fit into the lock. And when that happens, that enables the virus to enter the cell. So the key is this receptor called the ACE2 receptor binding to the spike protein on the virus. The virus then gets into the cell, causes an infection, and then, of course, the possibility of having symptoms of COVID-19. Well, of course, the way that we try to combat this is by the vaccine. And this has been a remarkable development. The vaccines for this disease have been developed faster than any other vaccine ever in history. Prior to this time, the quickest that any vaccine has come to market was about 4 years. Now we're talking less than a year. Although that is a little bit misleading in the sense that the research into these kind of vaccines did not begin with the notice of the SARS-CoV-2 virus. Messenger RNA vaccines have been researched now for well over a decade because researchers, of course, knew that some kind of a pandemic was looming. So there was already research into various kinds of vaccines. And of course, the existence of COVID-19 precipitated the situation. And it got greater involvement of scientists around the world than we have ever seen before. There was extensive sharing of information. Even rival companies were sharing information. So this really has been a great scientific accomplishment. I think it parallels something like the Manhattan Project, you know, when every effort was put into developing the atom bomb during the Second World War. This is a very similar kind of situation, except this time the war is against the virus. Everything that we're going to learn about the vaccine revolves around this spike protein because, as I've mentioned, this is the key for entering into a cell. And that is what we want to prevent. We want to prevent this virus from infecting a cell. This is where the immune system comes in. What we need to do is trick the immune system into thinking that it has been invaded by a virus so that it generates antibodies. Now, these antibodies are special protein molecules that are churned out by cells of the immune system. And the idea is that they form on a first exposure to the spike protein, and then the next time that they encounter this protein, they will bind to it and therefore prevent it from binding to the ACE2 receptor, prevent it from entering a cell. The idea is to get the antibodies formed without actually invading the body with a real virus, because of course that can cause infection. The idea then is to somehow introduce only the spike protein into the body. The immune system recognizes this as some sort of foreign intruder and will develop antibodies to it. And if at some time in the future the real virus should be encountered, these antibodies will recognize the spike protein on its surface and attempt to neutralize it. The first vaccine that entered the market was a vaccine, the Pfizer vaccine, that was based on technology that's referred to as the messenger RNA technology. And this is the first time that this particular platform has ever been used in a vaccine in humans. It has been used by veterinarians in animals before. So let me explain to you exactly what is going on here. So once again, we're back to this schematic of the virus, and you see the spike protein on its surface. And inside of the virus, you have its genetic code. It's RNA that tells it which proteins to produce. One part of that RNA, one gene, let's just highlight it there, codes for this spike protein. This has been analyzed. The Chinese, a year ago, January, already put this information out. So it was available to everybody. So I guess they should get some credit for doing that. Although, of course, there are a lot of skeletons in the Chinese closet because not all of the information that they released was timely, but they did release the genetic code of the virus. So once scientists knew the genetic code and identified the gene that codes for the spike protein, they were able to synthesize that gene in the lab. And this little piece of the RNA, this particular gene, codes only for the spike protein. So they generated that in the lab, chemical synthesis, and they enveloped it in what is called a lipid layer or a fatty layer to allow it to be properly preserved and to allow it to diffuse into a human cell. This is what we have inside of that vaccine. This is what is being injected. The messenger RNA that codes for the spike protein, and it gets into the cell. It doesn't go into the nucleus of the cell, it goes into the cytoplasm, which means that there's no way that this piece of genetic material in any way can enter the DNA, which is in the nucleus. So you cannot be somehow genetically modified with this vaccine. But that, of course, is part of the fear-mongering that is put out there by the anti-vaxxers. So once you have put the vaccine into arms of people, it gets into the bloodstream, it gets into cells, and there it sends the message. It says, now produce some spike protein. So the cell begins to produce some spike protein. It puts it out on its surface, and antibodies then see it and form. And the next time, of course, they will recognize an invading cell. But the fortunate thing about this whole business is that it is not only antibodies that form in response to the spike protein, the immune system also forms what are called T cells, which also have the ability of neutralizing an incoming invader, a foreign virus, by a totally different mechanism. So even if there is a lack of antibody formation due to a vaccine, and you've heard a great deal about to what extent antibodies form in a vaccine, the fact is that they also trigger the formation of T cells, which are also extremely important. So you can still get the benefit of a vaccine, even if the antibody production in response to the vaccine is quite low. The first one that we encounter, of course, is Pfizer, because this was the first one off the starting line, the first one that got into people's arms. And it is one of these vaccines. It's a messenger RNA vaccine. Unfortunately, in a sense, it has to be stored at a very cold temperature. It has to be stored at a dry ice temperature because the lipid layer in it is only stable at that temperature. But this is not such a big issue. Dry ice is relatively easy to produce, and this is not really the big stumbling block here. The question, of course, is how good such a vaccine is. What is its effectiveness? And the only way you know that is by doing testing. So let's take a look at the trial on which Pfizer based the data that it submitted to FDA in the US and eventually got this emergency use approval. So there were 22,000 subjects in the vaccine group and 22,000 in a placebo group randomly selected from the population. These, of course, were all volunteers. And half of them given the vaccine, half given the placebo. 162 developed COVID-19 symptoms after 3 months in the placebo group, but only 8 developed symptoms in the vaccine group. So obviously, looking at that numbers, you get the message that the vaccine works because there were a lot fewer cases in the vaccine group. Now, there are a couple of things to note here. One is that the trial was only 3 months, which is not a very long time, and that altogether, we're only talking 170 subjects who came down with symptoms out of the 44,000 people here. So the incidence of the disease was quite low. And we're basing all of this recommendation of the so-called 95% on 170 subjects. Of course, when you subject this to statistical analysis, it turns out that that is statistically significant, meaning that these results were not arrived at by chance alone. So the vaccine does work. But the question is whether or not this kind of efficacy is going to be maintained when the vaccine is out there in the general population, because efficacy and effectiveness are not the same thing. Efficacy is what we find in a trial, in an experiment. And that's the experiment that I just described to you. Effectiveness is what happens in the general population. So the trial is just a model, hopefully a good one, for effectiveness. But as we've seen before with other vaccines, generally the efficacy that is seen in trials is higher than what we see in effectiveness in the general population. That being said, though, the data that we're seeing now from Israel is quite comforting. Israel is really the prototype these days that everyone is looking at because they have a very, very high vaccination rate. Now it is approaching 70% of the population. And the vaccination started, as you can see, near the end of December. And we know that it takes about 2 weeks for the body to build up antibodies to the vaccine. So look at that. By the middle of January, and that's the time that antibodies started to build up, you begin to see a decline in hospitalizations. And let's face it, that is really what we are after. That's what we want to see, a decline in hospitalization, because everyone can put up with symptoms of a cold or a mild flu. That we can deal with. We don't want to end up in a hospital, and obviously we don't want to end up 6 feet under. So by the middle of January, hospitalization rates started to decline. And by middle of March, as you can see, declined very, very much. Today, and I got this information just this morning because I do have a son-in-law who's a physician in Israel, and the hospitalization rate has declined even further than that. So the effectiveness seems to be there for the Pfizer vaccine. And just yesterday, again, we got some data from Pfizer about how long the antibodies last, because this, of course, is a situation that we're not sure of, how long we are protected. And at first, the concern was that it might only be, a month or two. Now they're pretty confident that it's at least 6 months and probably more. And we also now know from data released yesterday by Pfizer that it works in teenagers as well. They now have carried out a study, 12 to 16-year-olds, and it works as well as in everyone else. Second off the starting block was Moderna. And again, this is the same kind of vaccine. Moderna is also messenger RNA vaccine. It is not identical to Pfizer. The lipid coating that you have around the molecule is different. These are proprietary, so we don't know exactly what the differences are, but the dosage is not the same. So you cannot take first dose Pfizer, second dose Moderna, or at least, I mean, there's no evidence one way or another because no one has done that study. But the recommendation is that you do not mix these. All right, well, of course, Moderna also was able to make it onto the marketplace because they had a trial. In this case, transportation is easier because this can be done at ordinary refrigeration temperatures. It doesn't need dry ice. The study was somewhat smaller than Pfizer's, although 30,000 people is still quite significant, 15,000 in the vaccine group, 15,000 in the placebo group. So what do we see? 185 people developed symptoms in the placebo group, and the length of the study was the same as Pfizer's, about 3 months, and only 11 developed symptoms in the vaccine group. So once again, you're looking at 185 compared to 11. So obviously, the vaccine works because it protects people. You have far fewer people developing symptoms in the vaccine group than in the placebo group. And again, when you make the calculation, 185 out of 196, 196, of course, was the total number of people who had symptoms. And if you just do the arithmetic here, 185 over 196 works out to 0.94. So that's your 94% efficacy. Sometimes you will see this reported in the literature, much to my annoyance, as 94.1, which is ridiculous. This cannot be known to 3 significant figure accuracy. In fact, even the 94, of course, has a certain degree of uncertainty built into it. But the fact is that both Pfizer and Moderna numbers were higher than anyone expected. It is indeed very, very impressive that we have over 90% effectiveness here. Nobody expected that. The FDA was willing to let the vaccines go at 50% efficacy. So doing a lot better here. But what is really noteworthy, and this is critical, you have to remember this, is that the efficacy was 100% when it came to serious cases that required hospitalization. That is very important to note, because as I said earlier, we can all put up with the mild symptoms. We just don't want to end up in the hospital. Next off the line were the viral vector vaccines. Now, this is a different technology. This has been used before. In this case, they take an already existing virus, a cold virus, a so-called adenovirus, that cannot multiply in the body. And they take out its genetic material and replace it with the genetic material that codes for the spike protein. So here's a little visual representation. It's a different kind of virus. It's not the one that causes COVID. And they insert into its genome the information to produce the spike protein. This cannot cause disease, and it cannot incorporate its DNA into human DNA. Again, that's some fear-mongering that is put out there by the anti-vaccine people. So there's no concern here about genetic mutations or anything like that. The efficacy was somewhat lower, 76%. But again, this requires only normal refrigeration. And when people saw 76%, less than 90%, they started saying, well, I don't want that vaccine. They started shopping around for vaccines, like you would shop around for a vacuum cleaner. You look at consumer reports and decide which vacuum cleaner you want. Do you want the Dyson or do you want the Shark? This is not a good analogy for the vaccine. Here, you're not shopping around for a vacuum cleaner. You're determining whether you want to have a vacuum cleaner or have no vacuum cleaner. So the fact that it's somewhat less effective is not all that important, and you'll understand in a moment why I say that that is not all that important. Now, of course, there are some issues, as you well know, that have arisen with the AstraZeneca vaccine. In Europe, they noted a very, very, very small number of cases, mostly in younger people and in women, but again, just a handful of cases of an unusual type of blood clot caused by a condition known as thrombocytopenia, where your blood platelets are not working properly. This, of course, has caused a lot of commotion. And just a couple of days ago, the Canadian government has decided that for now, they would stop the use of this vaccine in people under the age of 55. Over the age of 55, the benefits outweigh any kind of risk. But even under the age of 55, the risk is very, very small. And there have been no cases in Canada or in the US that have been noted with these blood clots. And it's not even clear that in Europe, the incidence of these blood clots was greater than what you would expect in the general population. But nevertheless, this is worthwhile looking into. And so that's why Health Canada has temporarily stopped this vaccine. The Johnson & Johnson vaccine is also one of these adenovirus vaccines, viral vector vaccines. And it is a single dose vaccine, which of course is a significant benefit because you don't have to go back for a second dose. And as you know, that second dose is an issue because the original study done by both Pfizer and with Moderna was that the second dose was given in one case 21 days, the other 28 days after the first dose. That's how the trial was done, and that's what the companies are recommending. However, in Canada and in some places in the US and elsewhere in the world too, experts have made the decision that it is better to stretch out the time between the first and the second dose and give more first dose to more people. There's going to be a greater benefit to society by protecting more people with a single dose, even though that single dose may not be as protective. Although the data indicate that the single dose, in fact, after 2 weeks, gives you upwards of 80% protection. So it is still very good. And the experts that I've spoken to, and I've spoken to a lot of them, don't think that it is a big issue if the delay is a couple of months. Of course, if you're looking at an individual, yes, it would be better to abide exactly by the dosage that the trial showed, because that's what the experiment showed. But statistics apply to populations, not to individuals. We want to make sure that we protect as many people in the population as possible, and a single dose will do that. In terms of efficacy, the Johnson & Johnson is anywhere from 66 to 85%, depending on where the study was done, because they did it in many different areas of the world. But again, people look at this and say, oh, it's less than Pfizer's, less than Moderna, I don't want that. Okay, let me just discuss the nuances here for a moment. Oh, incidentally, the Russian vaccine, which has the clever name of Sputnik vaccine, because that, of course, insinuates that they are first. Sputnik was the first satellite in space. This is also an adenovirus vaccine, a viral vector vaccine. And based on the published results, it is as good as any other vaccine. Of course, people have raised the question of whether or not you can trust the Russians, and there's no simple answer to that. But you know, while one can certainly criticize the Russian political system, the fact is that Russian science is very good. So there's a good chance that they did come up with an effective vaccine. Of course, what we're telling people is, don't worry about which vaccine to get, just go and get the vaccine. When I went, I never asked which one I got. I did find out, because they do tell you it was the Pfizer, but I would have gotten whatever they were offering. The next question that comes up is whether or not you should get an antibody test to see whether or not the vaccine is working for you. Are you generating your antibodies? All the experts agree that no, you should not do this. And I don't really need to get into the nitty-gritty details here, but the fact is that antibody production in response to a vaccine is not exactly the same as in response to having naturally combated COVID-19. And there are all kinds of differences here. It does not give you a good picture to do this test. So there's no point in doing that. Now, this is the numbers that are bandied about. And I hear this all the time. I want the Pfizer's 95%. I don't want the Johnson & Johnson at 66%. I think this is the wrong way of looking at it for several reasons. One, as I told you, these numbers are based on rather small trials. So there's a big margin of error here, but much more important, every single one of these vaccines has been 100% effective against death and hospitalization. That is the critical thing. We don't want our medical system to collapse with overburden. And if you are kept out of the hospital, that's what the benefit of the vaccine is. So it doesn't matter which one, they all do this. Now, why is it, for example, that the Johnson & Johnson was somewhat lower in efficacy? Because you can't compare apples to oranges. The Moderna and the Pfizer trials were done earlier than the Johnson & Johnson trial. The variants already were circulating when the Johnson & Johnson trial was done, which probably is the reason that we see lower efficacy. If the Moderna and Pfizer vaccine were done now, I think we would have the same kind of results as the Johnson & Johnson. So they all work, they all keep us out of the hospital. Now, of course, the question that many of you have is, what about cancer patients? And here, there's only one answer. The bottom line is that vaccines work, you should get vaccinated, but you check with your oncologist, because there are some cases of cancer, there are some types of cancer where there may be an issue. As you know, cancer patients are more prone to any kind of infection because their immune system is not working quite as well. So there's absolutely no reason for cancer patients not to get the vaccine. All indications are that you should get the vaccine because you have reduced immunity. But as I said, there are some cases that need to be discussed with the oncologist. But the vast percentage, largest percentage of cancer patients should get the vaccine. I mentioned this business of mutations, that the Johnson & Johnson trials were done at a time where the mutants were already out there, or the variants. What does this really mean? I think it's instructive to take a look at this again, and we'll go back to our original model, where we take a look at the RNA, the genetic code inside of this virus. And I told you that part of this RNA, a little piece, the gene, one fragment of RNA, which we call a gene, gives the instructions for the virus or for the protein on the surface, the spike protein. Every time that a virus replicates, there's always a chance of making an error. And that error is what causes a mutation. Now, this spike protein, which we represent in a very simple way with, this spike on the surface of the virus, is actually a very complex molecule. Every little ball in this model is an amino acid. So the spike protein is this large conglomerate of amino acids. And if you have a change in just one amino acid, which is brought about when there is an error that is made in the replication of this virus, that error causes a change of one single amino acid, which may be meaningful or not. In the case of this specific change, where a molecule of aspartic acid was changed to glycine, we have a mutation. This is what gives rise to this variant. This is the one that we saw first appear in the UK. Now, the question is, what difference does this make? It turns out that in this case, it just affects the folding pattern of this protein just enough to make it fit the receptor better. It's like lubricating the key. The key unlocks the lock better so that the virus can infect the cell and replicate. Every time that viruses replicate, there's always a chance of making an error. Most of these errors do not lead to anything because they're in part of this protein that does not affect how it binds into the receptor. But the one that I just showed you here is this mutation that we first saw in the UK, and that does make a difference. When you change that one amino acid, and the terminology here is D614G tells virologists exactly which amino acid and where in the protein was changed. This turns out to have made a difference. It made it more infective. And of course, since that time, we have learned that there are many other possible mutations that have given rise to variants, and we've had the South African variant. Now we have variants in the US as well. And as soon as a variant starts to appear, it starts to get into the population. And as you can see, this UK variant first appeared last January, and by April, it took over. It was being seen in the general population. And now here, of course, we are seeing a number of variants that are appearing. And of course, the question is, are the vaccines effective against those variants? And right now, it looks like they are effective. They may not be quite as effective, but they certainly work. And also, you have to realize one thing. That is that these variants can only occur if someone is infected with the virus. So the best way to prevent the formation of these variants is to keep as many people from being infected in the first place, because infection is the time that variants can form. So the bottom line here with the vaccines is that researchers have done an excellent job in developing the different kinds of vaccines. We don't know how long they are going to last in terms of forming antibodies. We don't know if we're going to need boosters, but we have a very, very good start. But we still have to couple it with the safety measures that we've been told. It doesn't mean that if you've been vaccinated, you can give up the masks. We should still be wearing the mask and keeping the distancing, etc. Talking about the masks, just 2 days ago, we had this scare here in Quebec, where a type of mask that has been widely distributed to school boards, daycare centers, etc., masks that some people have been wearing for 6 months, have been pulled from the market because they are releasing supposedly tiny particles of a material called graphene. Now, graphene is a fascinating material. It can do many, many things. It is, believe it or not, stronger than steel. It conducts electricity and heat better than any other known substance. It's flexible, and it's a great filtering aid. So there are reasons to put it into masks. But apparently Health Canada has found that one particular kind of mask is releasing tiny particles. I don't know of what, because they haven't really released any information, but they supposedly have some information about some impairment of pulmonary function with this particular kind of mask. So of course, we're going to take Health Canada's word on this and not use these kind of masks, and they have been taken off the market. But I can't really theorize on what is going on here, because I will quote Sherlock Holmes: it's a capital mistake to theorize before one has data, because one insensibly begins to fit the facts to the theory instead of the other way around. So we'll wait and see, but the other masks that are out there are safe. So now what? Where does all of this take us? I don't have a crystal ball. Actually, that's not true. I do have one. And when I look into it, what do I see? I see the virus. It is not going to disappear next week or next month. We are going to live with this. But we have learned to live with the flu virus. We have learned to live with other viruses as well. And chances are that if we get to herd immunity, where enough people have been vaccinated and enough people have contracted the disease to develop antibodies, we have a chance of squeezing this into the background and getting back to a life that is more or less normal, although it will be a new normal. But for now, we still have to keep the social distancing. We have to make sure indoors that we are far enough from people. So, the 2-meter distance for sure. We can't relax. It is right now, when we are on the road to herd immunity, we don't want to compromise the situation. There is hope. We are driving down a road of hope. And science will eventually, perhaps not vanquish this virus totally, but it will make it less important. However, remember that if you hear of any solution that is simple, it is going to be wrong, because the path to good science is long, very curvy, and but eventually we will get there. Global vaccination is going to be the answer. There are 9 billion people or so in the world. We will have to eventually vaccinate most of them, which is going to be a challenge, but we're on the road. When we look down that tunnel, there actually is a glimmer of light there because of the vaccine. And that glimmer is getting brighter and brighter week by week. We're learning more and more. It's an incredible scientific triumph. And I think by this time next year, we will be on pretty well in a normal situation. And life will go on, as Robert Frost told us. Unfortunately, it will not go on for everyone, because we're not going to wipe out the virus, but we are going to learn to live with it. So that's an encapsulation of what we know today. If you want more information, we have lots of stuff on our website, literally thousands of articles of all kinds. You can also go there to sign up for our weekly newsletter, and that comes to you free, of course, every Saturday morning. It's full of information that I hope is captivating and entertaining. So thanks very much for listening, and if there are any questions, certainly we can handle them. I think I probably covered a lot of the ones that you have submitted already, but if there's anything more, certainly I can give it a shot.
Dr. Schwartz, I want to ask. You hear me, please?
I hear you.
In Israel, there is a young woman. She was 22 years old. She took the second dose. She had inflammation in the muscle of the heart, and she passed away. What you can tell us about the side effect of the second dose?
Okay, what I can tell you is that from one single episode like that, which is one case, we cannot say anything. This is what we call anecdotal evidence. Whether it's related to the vaccine or not is absolutely impossible to say. It is not likely from what has been seen in now millions and millions of people being vaccinated. It is true that you tend to have a greater reaction to the vaccine after the second dose. That's true. But the situation that you described is not one that has been, described in the literature. Of course, that doesn't mean that it cannot happen. The incidence of any such adverse reaction to the vaccine is extremely low. In fact, it seems to be lower than with other vaccines. But no matter what kind of medical intervention there is, there's always going to be some type of side effect. That's always possible. We're always bent on weighing the benefits against the risks. And there's no question that the benefits of the vaccine outweigh the risks. There are going to be some cases, very unfortunate ones, where the vaccine may cause a problem. But my concern from the very beginning, when we started to talk about this vaccine, and I've had my battle with the anti-vaxxers, my concern always has been that as soon as there's any kind of adverse event in the time vicinity of having taken the vaccine, it will be connected and the vaccine will be blamed. People have all kinds of problems. People have heart attacks, people have strokes, people have aneurysm, people have all kinds of things, right? Routinely. But if it happens to be close to the time that you got the vaccine, you may make the connection, whereas actually there may not be connection. So what we will always have to look at is the incidence of side effects greater among the vaccinated people than the general population. And in the case of these vaccines, it looks like it is just like any other vaccine. It is not any worse.
Thank you, Dr. Joe. I do want to remind people to please try and ask your questions in the chat, just so we can keep control of things. I do have a bunch of pre-submitted questions, many of which you've answered already. Something that's coming up a few times is, can you comment a little bit on the delay between the two doses? Somebody posted about an article in the New England Journal of Medicine that Pfizer is only 47% effective after one dose after a study in Israel. People are wondering, especially for cancer patients who have heard that if you wait more than the 21 days, it's not as effective. Do you have any comments on that? Do you have any knowledge on that?
Yes. Certainly, a single dose is not as effective as having the two doses. I mean, nobody argues against that. That's what the trial has shown. Now, just how effective one dose is, there have been a number of studies on that. And they range anywhere from what you just suggested, 47% to over 80%. When you have so many different trials, you kind of look at the average, and the average is that it's pretty effective. I mean, it's in the 60 to 70% range after one dose. Of course, we don't know just how long that effectiveness lasts, because there haven't been any good studies on that. But again, this is a question of just how social conscious we are, because there's no doubt that for the single person, it is better to have the two doses exactly as the trials showed. But how are you going to save more lives? By giving the two doses to people, or by giving a single dose to more people? And this is where statisticians come in and have concluded that we are going to save more lives by giving one dose to more people. But of course, that means that each one of us is at greater risk. So it's a question of how you look at this. Whether you're going to look at it egotistically, as of course most people will, or you look at it as contribution to society as a whole. And if you look at it like that, it makes more sense to give one dose to more people.
So it's a question of the individual versus the collective.
Absolutely. And if we had enough vaccine, which we don't, but if we had enough vaccine, obviously the best thing is to give it exactly as the trial showed.
Of course.
But we live in the real world.
Yeah.
We can't do it because we don't have enough vaccine.
Questions about, all of the data that's come out about AstraZeneca and the risk of blood clots. We have a number of breast cancer survivors on this call today who are curious, many of whom are on hormone therapies that put them at an increased risk of blood clots in the first place. Do you have any thoughts about what vaccine they should be taking, or again, it's just take whichever one is offered?
Well, at this point, the message is you take whatever is offered, and this very special type of blood clot formation that has been connected to, in this admittedly nebulous way with the AstraZeneca vaccine, is not the same kind of situation as people who are at risk for other blood clots because of the hormone therapy or other drugs. But I mean, the basic answer is that nobody knows, because the study has not been done. There's been no study on cancer patients taking AstraZeneca vaccine. So all one can do is make what is hopefully an educated guess on this. And that is that whatever vaccine you get, the benefits outweigh the risks. That's whether it's AstraZeneca or whether it's Pfizer. If you had the choice, I mean, based on the data that we have right now, based on the efficacy data and you know, this shadow of the blood clots, I mean, obviously, if you have the choice, you would go for the Pfizer or the Moderna.
Can you tell us a bit about, some people have asked about allergic reactions, some people who have had reactions to chemotherapy drugs in the past.
There are allergic reactions that are possible for any vaccine. The only serious allergic reactions that have been seen with this vaccine, and they have been remarkably few, have been in people who have been prescribed EpiPens for some sort of allergy. So it's only someone who is extremely allergic, that is, they have an EpiPen, that one would be worried. Even worried, I think, is too strong a word, because even with that, the chance is very small. But what the advice is that if you are in that category where you have been prescribed the EpiPen, obviously you take the EpiPen with you when you get the vaccine, and that you stay around longer than just the 15 minutes that is usually recommended. But obviously, any concern that you have, this is a time to raise that with your infectious disease specialist, because they will know about who is at risk. Now, there may be some very specific allergies that put you at greater risk, although I would not think that is, but that's, the experts would know that.
Can you tell us what exactly is the substance that causes an allergic reaction? What is that in the vaccine?
There's almost always a protein that causes an allergic reaction, and virus, as you know, I've mentioned, is full of proteins. It's not only the spike protein. I mean, it generates all kinds of proteins that are used in its replication process. Which protein one is allergic to, who knows? I mean, when you're allergic to fish, for example, you're allergic to some specific protein in the fish, but that doesn't mean that you're allergic to shellfish. You're usually not, because that has a different set of proteins, but it's almost always a protein to which one has an allergy.
Okay. So you said a little bit about the delay between doses in the vaccine for sort of the general population, but is there a difference in efficacy for cancer patients specifically?
I don't think anyone can give a concrete answer to that, because you have to have a trial. Okay. You'd have to have a trial where you have cancer patients who are given the vaccine at different time intervals and see if it makes a difference. And so that not having been done, so all one can do is make a guess. And the guess is that, I mean, there's no reason to think that it would be any different for cancer patients.
Okay. I think we've gone through the majority. Lots of questions came through with the same theme, different diagnoses, but should I get it if I'm in treatment? And the answer sounds like, yes, go get the vaccine. There may be nuances about when, depending on the treatment you're getting. I think we've gone through everything. I want to...
remember that the bottom line is that whatever complication you may get with the vaccine is a lot more preferable than the complications you get with COVID-19.
Yes.
Okay, you don't die because of the vaccine, you die with COVID-19.
What are your thoughts on traveling after you've gotten the vaccine, after you've been fully vaccinated?
Well, I mean, obviously your risk is reduced, but look, even if we take the numbers that we mentioned, the 90-95%, that's not 100%, right? So, I mean, out of 100 people, 5 can still be infected. So you're on there on an airplane with 200 people. Even if they have all been vaccinated, there's 20 of them for whom the vaccine hasn't worked, who can be transmitting the disease, who can be infected. So, right. You're always playing the numbers game. Yes, your risk is less, but if you don't travel, your risk is eliminated.
What about if you've had COVID?
Okay, that's a good question.
Yeah.
If you've had COVID, you obviously do have some antibodies. But the recommendation right now is that if you've had COVID, you still should get the vaccine. You're protected better with the vaccine than with the natural antibodies from what has been seen so far. However, one can argue that people who already have been, who have had the disease should go to the bottom of the list when it comes to the vaccination. It's less urgent for them to be vaccinated, but they should still be vaccinated.
What are your thoughts on the prioritization of the different groups? We had somebody talking about, you know, trying to see if we can prioritize young adults with cancer diagnoses over people in different age groups. What are your thoughts on how the government is prioritizing the distribution?
I don't know. I don't have enough expertise on that. I mean, this is where you have to give way to the epidemiologists and the statisticians and the infectious disease people who look at all of this. And I imagine that they have enough expertise to, I'm a great believer in listening to the experts, people who spend their lives studying these things, That's why I'm so annoyed when, I get questions from lay people off the street who say, well, I don't think that vaccine has been properly tested. It's been rolled out too quickly, It's very annoying when you hear that from people who have no idea what they're talking about, who don't know what a virus is, who don't know how a vaccine works, but they think that their opinion is as valuable as that of people who have spent their life in labs, virologists, who have worked on this, who know every nuance, who can tell you what it means when you change one single amino acid in that spike protein for another. Whose word are you going to take? Some anti-vaxxer on the street or someone who knows what they're talking about?
Fair enough. Get your information from the reputable sources. Somebody asked, if you're doing immunotherapy, can the vaccine make your drug less effective or increase the size of your tumor? What's the science behind that?
Yeah, I mean, these are things that are very much researched because these are very legitimate questions. But unfortunately, nobody really knows. Nobody really knows because the trials did not include cancer patients specifically. So again, you're just making guesses. And if, whether or not someone who's on immunotherapy is going to be differently affected, you cannot tell unless you've studied people who are, on immunotherapy. And this is where, your oncologists will certainly have an opinion on this because they probably have already dealt with this, although, on a case-by-case version, not having done, not in terms of studies, but they will have had their patients being vaccinated, and they will have had patients who have been on all kinds of immune treatments, and they may have anecdotally already noted something. And, although anecdotal observations are not really scientific, but science starts with making an anecdotal observation. So that's why, I say that for all these questions, you really should ask your oncologist because they already may have some personal evidence that has not been published.
So it sounds like the research is not necessarily there yet for cancer patients specifically.
It isn't because, what you really need to have is a trial, just like the trials that I just described, where all the subjects are cancer patients.
Right. So they were more on the general population.
Yeah.
Okay. I think we've gone through everything. Dr. Joe, I don't want to take up more of your time. I do want to thank you for doing this for us and for the over 100 people who are here. Thank you for coming. This will be recorded. I will send the link out to everybody who registered, and as well as you, Dr. Joe. And thank you again. And again, please make sure you get vaccinated when you can. And if you do have questions on your specific treatments, that is something you have to address with your healthcare team. And thank you again for coming. Take care, everybody.
Thank you, Doctor.
Thank you.
Thank you very much.
Bye.
Thank you. Bye.